Let's jump right in. If you have ever stepped foot inside an emergency room, you know that time is absolutely your most precious resource. And the threats you face, well, they aren't always visible to the naked eye. Today, we're looking at some of the most dangerous, stealthy, and rapid-acting culprits you're going to encounter on the floor. Enteritis causing bacteria. Imagine a patient rolling through triage presenting with severe dehydration, or worse, slipping rapidly into endotoxic shock. In those moments, your rapid assessment, your vital sign monitoring, and your immediate action literally mean the difference between life and death. So let's dive into this explainer and build up your clinical arsenal.
Now, this explainer is designed specifically as a direct clinical preparation tool for your official emergency nursing curriculum. So, whether you're studying through the Khan Yunis Training Center Emergency Nursing Program, or honestly, if you're a nursing student anywhere, preparing for the chaotic realities of the ER, this is for you. We are taking the microbiology straight out of the textbook and putting it right onto the hospital floor where you actually operate.
Okay, here's our clinical shift briefing. 1. The enteritis threat. 2. Identifying enteric fevers. 3. Opportunistic flora. 4. Severe dysentery and cholera. And finally, 5. Critical ER protocols.
All right, Section 1. The enteritis threat. Baselines for the ER.
Let's establish our biological baseline first. Enteritis-causing bacteria are gram-negative and they ferment glucose. Now, what makes this group so incredibly tricky on the floor is that many are actually just normal flora, living totally harmlessly in the intestines. But specific strains, like Salmonella, Shigella, and certain E. coli, are highly pathogenic. When they breach the system, they wage all-out war on the GI tract, and as a nurse, you're going to see a really rapid deterioration in your patient's baseline.
Moving on to Section 2. Identifying enteric fevers, the systemic threats.
Okay, during your physical assessment, this is exactly how you differentiate the systemic threats. On the left, we've got Salmonella typhi, typhoid fever. You need to monitor their vitals for a distinct step-ladder fever that progressively climbs higher and higher. During your skin check, keep an eye out for a rash on the chest, back, and abdomen, along with intense sweating, chills, and even bone and spleen inflammation. Now on the right, paratyphi presents a bit milder, a 1 to 10-day incubation period, a milder fever, diarrhea, and a pink rash that's usually specific to the chest. For both of these, anticipate doctor's orders for ampicillin or chloramphenicol to knock down the severity.
But remember, timing is literally everything in the ER. Your absolutely crucial nursing action for these enteric fevers is to secure blood cultures, specifically during the feverish stage. That's when the bacteria are actively circulating in the bloodstream. Do not wait. You'll also be collecting urine and stool specimens for isolation. Keep in mind, serological Widal tests are only really useful after about 2 weeks to detect antibodies, so getting that initial blood culture while the fever is spiking, that is entirely on you.
All right, Section 3. Opportunistic flora, E. coli, Proteus, and Klebsiella.
Let's look at pathogenic E. coli. While it's normally a beneficial resident, when it goes rogue, it's bad news. You'll see enteritis, peritonitis, cystitis, and devastating infantile diarrhea. But your absolute grave danger here is endotoxic shock. These gram-negative bacilli can trigger a massive, full-body systemic response. You need to be continuously monitoring for sudden drops in blood pressure and tachycardia, because I'm telling you, if they crash hard.
And this brings us to a really vital rule of emergency nursing advocacy. It is much better to culture a specimen of stool before initiating antibiotic therapy. We are seeing a super alarming increase in drug-resistant strains of E. coli to meds like tetracycline, neomycin, chloramphenicol, and streptomycin. Honestly, if you hang that IV antibiotic before getting the sample, you destroy the exact evidence the lab needs to find the medication that will actually save them. Always culture first, treat second.
Let's briefly contrast 2 other opportunistic threats you'll see. Proteus is highly motile and it loves to target the urinary tract, so monitor closely for UTIs, suppurative abscesses, and summer diarrhea in children. Klebsiella, on the other hand, takes a totally different path, targeting the respiratory system. For this one, you'll be monitoring O2 stats and listening to lung sounds for secondary infections like severe sinusitis, chronic bronchitis, and bronchopneumonia. You gotta know your enemy's territory to guide your assessments, right?
Okay, I want you to think like a triage nurse for a second. Picture this. A patient rolls through the doors. They have a known incubation period of just 48 hours. They are presenting with severe bloody diarrhea, abdominal colic, and their intestinal mucous membrane is becoming necrotic and ulcerated. So which pathogen are we dealing with here?
That brings us to Section 4, severe dysentery and cholera, the ER emergencies. If you guessed Shigella, you hit the nail right on the head. It causes bacillary dysentery by releasing a really powerful exotoxin, which leads to a dangerous pseudomembrane. And man, this stuff spreads like wildfire through contaminated fingers, food, and fomites. Think bed sheets and thermometers. Your immediate nursing priority here is initiating strict contact precautions and meticulous hand hygiene. While sulfamethoxazole is the medical treatment, your real job is containing the spread and managing their fluid loss.
Now, let's look at arguably the most dramatic clinical decline you will ever witness, Vibrio cholera. This comma-shaped bacterium is utterly relentless. It kicks off with severe, painless rice water diarrhea, basically clear fluid with just flecks of mucus. Then comes sudden vomiting without any prior nausea at all. This quickly leads to intense, rapid dehydration and severe muscular cramps. The patient's skin is going to become cold, clammy, and literally wrinkled from all that volume loss, with their eyes noticeably sunken in. Finally, they hit profound hypotension with a weak pulse and decreased urine output. As their nurse, you absolutely must initiate strict input and output monitoring. This patient is crashing incredibly fast.
Which leads us perfectly into Section 5, Critical ER Protocols, Taking Action.
When you suspect cholera, the lab diagnostics are highly specific. First, the stool is cultivated on alkaline peptone water for 6 hours and then plated onto a TCBS medium. As the nurse, you have to ensure the lab knows you suspect cholera, so they actually utilize TCBS. It's the essential medium required for Vibrio cholera to grow. After 10 to 24 hours, gram staining will reveal those distinct red gram-negative rods, which are then confirmed by agglutination with antiserum.
But listen, while the lab does their 24-hour work, you are the one saving the patient right now. Cholera ER management is all about speed. Step 1, establish large bore access and administer intravenous saline immediately. You must rapidly restore those lost fluids before the organs start failing. Step 2, administer the prescribed tetracycline capsules to kill the organism. And just a quick note, the cholera vaccination is only effective for 6 to 9 months, meaning your rapid IV fluid resuscitation is the true lifesaver here. So, we've covered the systemic fevers of Salmonella, the opportunistic betrayal of E. coli, the necrotic damage of Shigella, and the rapid, terrifying strike of cholera. As an emergency nurse, you are the absolute frontline defense against these microscopic rogues. So when the next patient rolls through those ER doors crashing from severe GI distress, are you just going to see the symptoms, or will you recognize the pathogen, lock down your unit, and initiate the life-saving protocol? Review these concepts, trust your clinical baseline, and stay sharp out there. Thanks for joining me on this explainer.